Hello, I'm Jennifer Watkins from the NHSN Protocol and Training Team. Welcome to the NHSN 2025 training session for pneumonia event surveillance. The objectives for this session are to summarize the 3 pneumonia algorithms and the requirements for each, describe eligible imaging test evidence, signs and symptoms, and laboratory evidence for pneumonia, explain secondary bloodstream infection assignment to pneumonia, and apply the pneumonia surveillance definitions to case studies. The next couple slides are references with abbreviations that are used on slides throughout the presentation. However, I will do my best during the presentation not to use abbreviations when speaking. Okay, time to begin our journey through NHSN pneumonia event surveillance. I want to thank Samantha for noting the differences between VAE and pneumonia surveillance. Now I'm going to ask you to switch gears because the Chapter 2 Identifying HAI's guidance does apply to the pneumonia surveillance definition. The first step to performing NHSN pneumonia surveillance is to locate the pneumonia-specific resources. The Pneumonia Events webpage can be accessed from the left navigation bar located on all of the NHSN web pages under the Patient Safety Component heading. The pneumonia webpage has links to resources necessary for conducting pneumonia surveillance. A few highlights are the pneumonia protocol, the pneumonia training page, and the pneumonia frequently asked questions, or FAQs. I highly recommend you review the pneumonia FAQs as they provide additional guidance for applying some of the concepts of pneumonia surveillance, and you may find answers to some of your questions there. Also, the pneumonia event and denominator collection forms and tables of instructions are located a bit further down the page, and they also contain information necessary for accurate data collection. Take the time to become familiar with the pneumonia webpage and the materials provided, as they are important for understanding and applying the pneumonia surveillance definition. The NHSN Pneumonia Protocol is Chapter 6 of the NHSN Patient Safety Component Manual, which can be accessed from the Pneumonia Events page or directly from the link provided. You may find it helpful to refer to the Pneumonia Protocol during this presentation. So when and where can you conduct pneumonia surveillance? Pneumonia surveillance is only available for in-plan reporting for mechanically ventilated patients in pediatric locations. However, pneumonia surveillance can be performed off-plan for any patient, regardless of age, location, or ventilation status. And of course, the pneumonia definition is available for secondary bloodstream infection, or BSI, assignment for all patients. Did that change? There we go, sorry about that. Now that we've located the necessary resources, let's start with an overview of the pneumonia definition. The pneumonia surveillance definition can be met with any of the 3 pneumonia criteria: pneumonia 1, pneumonia 2, or pneumonia 3. And when you meet pneumonia 1, pneumonia 2, or pneumonia 3, this is reported as a pneumonia event. To meet the pneumonia criteria, you must first meet the imaging element, and then you must meet the signs and symptoms element. And in the case of pneumonia 2 and pneumonia 3, you must also meet the laboratory element. And we'll explore these criteria and the elements more in depth later in the presentation. Additionally, there are footnotes in the algorithms that provide additional information and guidance for meeting the elements. The information in the footnotes must be incorporated into the decision-making process for determining if a pneumonia definition is met. And please note, the footnotes only apply to the element in which they are cited. The first pneumonia criterion is pneumonia 1, which is located in Table 1 in the pneumonia chapter. Pneumonia 1 is clinically defined, meaning no laboratory test evidence is required to meet the criterion. Required elements in the infection window period include imaging test evidence of pneumonia and signs and symptoms. Pneumonia 1 has 3 sets of criteria for signs and symptoms. First is any patient, which can be applied to patients of any age, including infants and children. Additionally, there is an alternative criteria that can be applied only to infants less than or equal to 1 year old, and an alternative criteria that can be applied only to children greater than 1 year old or less than or equal to 12 years old. The age-specific alternative criteria for signs and symptoms only apply to pneumonia 1. You can't use the signs and symptoms from the alternative criteria for infants or child to meet pneumonia 2 or pneumonia 3. And we'll explore the age-specific criteria more in depth when we cover the signs and symptoms element. Pneumonia 2, which is located in Tables 2 and 3, includes laboratory test evidence in addition to imaging test evidence and signs and symptoms. Required elements in the infection window period are imaging test evidence of pneumonia, signs and symptoms, and laboratory evidence as defined in the laboratory column of the algorithm. Pneumonia 3 is located in Table 4, and it can only be applied to patients who meet the pneumonia immunocompromised definition in footnote number 10 in the pneumonia protocol, and we'll cover this later in the presentation. Required elements in the infection window period are imaging test evidence of pneumonia, signs and symptoms, and laboratory evidence as defined in the laboratory column of the algorithm. And additionally, the patient must meet the pneumonia immunocompromised definition in footnote number 10 in order to apply the pneumonia 3 algorithm. When applying the pneumonia definition, remember, although there are specific criteria which can only be met by infants, children, or immunocompromised patients, these patients can meet any of the other criteria. For example, an immunocompromised patient can meet pneumonia 1 or pneumonia 2 or pneumonia 3. When reporting a pneumonia event, there is a hierarchy for reporting if more than one pneumonia event is met during the infection window period or the repeat infection timeframe. And this hierarchy can be found in the reporting instructions section in the pneumonia chapter. And here's our first knowledge check. Which pneumonia criterion doesn't require laboratory test evidence? Pneumonia 1, pneumonia 2, or pneumonia 3? And remember to place your answer in the chat.
Hey, Jennifer, everybody's saying A. Great job.
Excellent, you are correct. The answer is A, pneumonia 1. Pneumonia 1 does not require laboratory test evidence. It is clinically defined. However, pneumonia 2 and pneumonia 3 do require laboratory test evidence as defined in the laboratory column of the algorithms. All right, imaging test evidence of pneumonia is the main component of the pneumonia surveillance definition. If the imaging element is not met, the pneumonia definition cannot be met. Determining if the imaging test results meet the imaging requirement is the most challenging part of the pneumonia surveillance, so we'll be spending a bit of time reviewing this element. The imaging test requirement is the same for all 3 pneumonia criteria. New and persistent or progressive and persistent definitive imaging test evidence of pneumonia. And please note, there are 3 footnotes associated with determining if the imaging requirement can be met. And these are footnotes number 1, 2, and 13. And we're going to spend the next several slides breaking down the imaging requirement. The first part of the imaging requirement is identifying imaging findings that are representative of pneumonia. For the purposes of meeting the pneumonia imaging requirement, the following imaging findings are considered to be positive imaging test evidence of pneumonia. And these are infiltrate, consolidation, cavitation, and for infants less than or equal to 1 year old, pneumatoceles. However, there are certain alternative imaging findings that may be considered as potentially positive imaging test evidence of pneumonia. These include findings such as opacities, densities, and airspace disease, which are non-specific imaging findings that can be representative of any number of pulmonary processes, including pneumonia. So, if these findings are noted and are not documented as being representative of something other than pneumonia, such as, for example, atelectasis or pulmonary edema or chronic lung disease, they can be considered as evidence of pneumonia. And this guidance is found in footnote number 2 in the pneumonia protocol. The next part of the imaging element is a requirement for new and persistent or progressive and persistent imaging test evidence of pneumonia. Pneumonia may have rapid onset or progression, but it does not resolve quickly. Rapid imaging resolution suggests that the patient does not have pneumonia, but rather a non-infectious process, such as, for example, atelectasis or heart failure. So these imaging tests illustrate rapid onset of pneumonia. On day 1, the patient's lungs are clear, and the next day, the patient's lungs demonstrate evidence of pneumonia. So what do we mean by new or progressive? A finding is considered new if it was not present in the prior imaging test. For example, if an imaging report documents no findings of pneumonia, such as lungs are clear or no acute cardiopulmonary process noted, and the next imaging report documents findings of, for example, new consolidation or interval development of infiltrates, this would be considered a new finding since it was not present in the prior imaging test. A finding is considered progressive if the findings are worse in comparison to the prior imaging test. If the language in the imaging report supports that the imaging findings are progressing or worsening in comparison to the findings in the prior imaging test. For example, you'll see increasing infiltrates or worsening consolidation, or infiltrates are more extensive in comparison to prior imaging. These findings are considered to be progressive. And please note, we don't require clinicians to specifically use the words new or progressive in the imaging reports. If the language in the imaging report is consistent with these key words, we consider the new or progressive component to be met. These imaging tests illustrate persistence of imaging test evidence of pneumonia. The first imaging test demonstrates evidence of pneumonia that is still present 10 days later, with some improvement noted. Persistence of imaging test evidence of pneumonia is a requirement for all patients. So how do we assess for persistence? It is likely that a patient will have multiple imaging tests performed, and all temporally related imaging test findings must be reviewed to determine if the imaging requirement for persistence is met. If subsequent imaging test reports note rapid resolution of the findings or attribute the findings to another condition, this indicates that the patient does not have pneumonia. We recommend you review imaging test reports for at least 7 days, if they are available, to determine persistence. And while the imaging tests demonstrating new or progressive findings are required to occur within the pneumonia infection window period, the imaging tests used to determine persistence may occur outside the pneumonia infection window period. Let's look at a couple of examples of persistence. In the first example, the day 2 imaging test demonstrates new findings, and the day 3 imaging test demonstrates worsening of the prior findings. The subsequent imaging tests from day 4 through 12 continue to demonstrate evidence of pneumonia. You may note that the imaging on days 6 and 9 show improvement. If the patient is being treated for pneumonia, we would definitely expect to see some improvement. However, since the findings have not completely resolved, the infiltrates are still present, persistence of evidence of pneumonia is demonstrated. In the second example, the day 1 imaging test demonstrates a worsening finding of opacities, and the day 2 imaging test also shows opacities. In subsequent imaging tests, the findings are also described as infiltrates, densities, airspace disease, and opacities. And while different terms are used, since the subsequent findings are described as persistent in comparison to prior findings, we would interpret the evidence of pneumonia to be persistent. And just as a reminder, if findings such as opacities, densities, or airspace disease are not attributed to something other than pneumonia, for the purposes of the pneumonia imaging requirement, these findings can be considered as evidence of pneumonia. Now let's look at some examples where imaging test evidence of pneumonia is not persistent. In the first example, the day 2 imaging demonstrates new opacities that are worsening on day 3. And remember, if non-specific findings such as opacities are not attributed to something other than pneumonia, for the purposes of the pneumonia imaging requirement, they can be considered as potentially positive findings for pneumonia. So in this example, the imaging requirement for new or worsening findings is met. However, when assessing for persistence, the findings rapidly resolve. They are no longer present by day 6, which indicates that the imaging findings are not representative of pneumonia, but rather of a non-infectious process. And the clinical scenario in this example is a post-operative patient with uncontrolled pain who develops atelectasis. Once the patient's pain is controlled, the patient is able to cough and deep breathe and move effectively, and the atelectasis clears. In the second example, the patient presents with opacities on imaging, so the requirement for new findings is met. However, as in the prior example, the findings resolve rapidly and are no longer present by day 5. In this clinical scenario, the example is a patient admitted with acute heart failure, and the patient's pulmonary edema resolves after diuresis and adjustment of cardiac medications. In the third example, the findings alternate between opacities and findings of non-infectious disease processes. So the interpretation is that the opacities are representative of the underlying disease process. The clinical scenario in this example is a premature neonate with underlying lung disease related to prematurity. The examples on the prior slide are a good segue into the next topic, which is the challenge of differentiating between pneumonia and underlying pulmonary or cardiac disease with imaging test findings. And these imaging tests illustrate the similarity of appearance in findings for pneumonia and heart failure. For the purposes of the pneumonia imaging requirement, at a minimum, at least one definitive imaging test is required for patients without underlying pulmonary or cardiac disease. And note that I said at least one, not just one. Remember, persistence is a requirement for all patients, so if multiple imaging tests are available, they must also be reviewed for persistence of definitive evidence of pneumonia. However, for patients without underlying pulmonary or cardiac disease, if only one imaging test is available and the findings are definitive for pneumonia, the imaging requirement can be met. For patients who have underlying pulmonary or cardiac disease, 2 or more imaging tests performed on separate occasions, which we refer to as serial imaging, is required to demonstrate that the imaging findings are due to pneumonia and not a reflection of the underlying disease process. However, there is one exception to the serial imaging requirement. In instances where only one imaging test is available, it can be used to satisfy the imaging requirement for present on admission or POA determinations only. Otherwise, if only one definitive imaging test is available for patients with underlying pulmonary or cardiac disease, that single imaging test cannot meet the requirement. When assessing imaging findings, we often see findings that are equivocal for infection. So what do we mean by equivocal imaging findings? We mean that the imaging does not conclusively identify an infection or an infectious process. In other words, the findings may be due to infection or they may be due to a non-infectious process. For example, you may see one of the following: infiltrates versus atelectasis, or opacity may represent pneumonia or pulmonary edema, or consolidation consistent with pulmonary hemorrhage. So may be infection, may not be infection. What do you do if the imaging findings are equivocal for pneumonia? If imaging is equivocal for pneumonia, there is a process for determining if the imaging is usable for meeting the imaging requirement. And this is covered in footnote number 13 in the pneumonia protocol. When imaging findings are equivocal for pneumonia, you must first look to subsequent imaging tests for clarification. If the subsequent findings are definitive for pneumonia, the equivocal imaging is eligible for use. But if subsequent findings no longer show pneumonia, the equivocal imaging is not eligible for use. But what if there are no subsequent imaging tests, or if subsequent imaging tests do not provide clarification? For example, the findings remain equivocal, or the findings become definitive but then go back to equivocal. In this situation, you would look for clinical correlation to clarify that the equivocal imaging findings are representative of pneumonia. And for the pneumonia definition, clinical correlation is specifically physician documentation of antimicrobial treatment for pneumonia. It is important to note that if the imaging findings are not eligible, the image requirement cannot be met even if there is clinical correlation. Clinical correlation can only be used to clarify equivocal imaging findings. And let's look at some examples. In the first example, the day 1 and day 3 imaging tests demonstrate findings that are equivocal for pneumonia. Since additional imaging tests are available for review, you will first look to these imaging tests for clarification. And as with persistence, we recommend you review imaging tests for at least 7 days to clarify equivocal findings. In this example, the imaging tests on days 6 and 7 demonstrate definitive evidence of pneumonia, which clarifies the day 1 and day 3 equivocal imaging findings to be representative of pneumonia and therefore eligible for use in meeting the pneumonia imaging requirement. In the second example, the imaging findings on day 1 are definitive for pneumonia, but on day 3, the findings are now equivocal for pneumonia. The day 6 and day 7 imaging tests no longer demonstrate evidence of pneumonia, which clarifies the equivocal findings to not be representative of pneumonia, so the prior imaging tests are not eligible for use. In the third example, the imaging findings are persistently equivocal. In this scenario, if there is physician documentation of antimicrobial treatment for pneumonia around the time of the equivocal imaging tests, this clinical correlation can be used to clarify the imaging findings as representative of pneumonia, and the imaging requirement can be met. However, in this scenario, if there is no clinical correlation documented, the equivocal findings cannot be used to meet the imaging requirement for definitive imaging test evidence of pneumonia. I want to take a minute to talk about imaging reports. These are the radiologist's documentation of their review of the actual imaging tests. And this is the clinical documentation within the medical record that you should review to determine if the imaging element of the pneumonia definition is met. Imaging reports typically contain documentation of the findings or what the radiologist saw and impressions which is the radiologist's assessment of what the findings represent. And while the findings and impressions may be clearly labeled or documented in the imaging report, we realize that not all imaging reports follow this format. Therefore, the entirety of the imaging report must be reviewed and considered when making a determination of whether the imaging test demonstrates evidence of pneumonia. This is especially important when nonspecific findings, such as opacities, are documented. We must look to the radiologist's interpretation or impression of what the findings represent in the context of that specific imaging test. In summary, when determining if the imaging element is met, remember, the imaging test evidence is the same for all three pneumonia algorithms, and the imaging requirement must be met in order for the pneumonia definition to be met. Determining if the imaging test results meet the imaging requirement is the most challenging part of pneumonia surveillance. You can't just find one imaging test with a keyword and determine the imaging requirement is met. You must look at the whole imaging picture. And unlike imaging for other NHSN events, the findings must be new or progressive, and they must be persistent for all patients. Patients will often have multiple imaging tests performed, so multiple imaging test results over several calendar days will likely have to be reviewed to determine if there's imaging test evidence of pneumonia. And don't forget to incorporate the guidance from footnotes 1, 2, and 13 when assessing for imaging test evidence of pneumonia. All right, we're finally done with the imaging requirement. And now for knowledge check number 2. True or false? The pneumonia imaging requirement is met with the following imaging test findings. And I'll give you a moment to look at the findings and place your answers in the chat.
Jennifer, we're seeing all true in the chat.
Excellent. The answer is true. In this scenario on 315, there's development of new findings definitive for pneumonia, and these definitive findings persist in the subsequent imaging tests on 318, 320, and 321. And although the 321 imaging does demonstrate some improvement, since the finding of infiltrates is still present, persistence is met. And here's knowledge check number 3. True or false? The pneumonia imaging requirement is met with the following imaging test findings.
Jennifer, they are all saying false today.
All right, good job.
Yeah.
You're correct. The answer is false. In this scenario, the 5-2 imaging demonstrates a progressive nonspecific finding of increasing opacities. And remember, as per footnote number 2, opacities can be considered as eligible findings if not attributed to something other than pneumonia. But since persistence of eligible findings is also required to meet the imaging requirement, you must review subsequent imaging findings. And in this scenario, the 5-3 imaging findings are equivocal. The opacities are now documented that they may be due to infection or they may be due to a non-infectious process. As per footnote number 13, when imaging findings are equivocal, you must first look to subsequent imaging tests for clarification as to whether the equivocal findings represent pneumonia or non-infectious process. The next imaging test on 5-5 now attributes the findings to a non-infectious process, and the 5-6 imaging test also demonstrates a non-infectious process. Therefore, the imaging requirement for persistence of definitive evidence of pneumonia is not met. All right, now that we've covered the imaging element, let's talk about signs and symptoms. And I promise this is much easier than the imaging requirement. If you recall, Pneumonia 1 has 3 different sets of criteria for signs and symptoms, and we'll look at these individually, starting with signs and symptoms for any patient regardless of age. And remember, this criterion can be applied to any patient, so even infants and children can meet this criterion. The signs and symptoms requirement includes one of the following: qualifying temperature, or leukopenia or leukocytosis, or for patients 70 years old or older, altered mental status with no other recognized cause. Plus, you must have at least 2 additional qualifying signs and symptoms. The qualifying signs and symptoms must be from different bullets. So for example, if there is tachypnea and rales in the infection window period, this would qualify as 2 additional signs and symptoms. But if there is dyspnea and tachypnea in the infection window period, this would be considered a single sign or symptom since they are from the same bullet, and an additional sign or symptom from a separate bullet would also be needed. The first alternative age-specific criterion is for infants less than or equal to 1 year of age. To meet this criterion, the infant must have evidence of worsening gas exchange, plus at least 3 additional signs or symptoms from different bullets. The second alternative age-specific criterion is for a child from greater than 1 year old to less than or equal to 12 years old. And to meet this criterion, the child must have at least 3 qualifying signs and symptoms from different bullets. The signs and symptoms criteria for pneumonia 2 requires one of the following: qualifying temperature, or leukopenia or leukocytosis, or for patients 70 years old or older, altered mental status with no other recognized cause. Plus, they must have at least 1 additional qualifying sign or symptom. Remember, pneumonia 2 does not have age-specific criteria. The same signs and symptoms criteria apply to all patients meeting pneumonia 2, regardless of age. You cannot use the age-specific signs and symptoms from pneumonia 1 to meet pneumonia 2. The signs and symptoms criteria for pneumonia 3 requires that the patient must meet the pneumonia immunocompromised definition in footnote number 10, which we'll look at in a moment, plus at least 1 additional qualifying sign or symptom. And of note, leukocytosis and leukopenia are not eligible signs or symptoms for pneumonia 3. And again, there are no age-specific signs or symptoms criteria for pneumonia 3. The same signs and symptoms criteria and immunocompromised criteria apply to all patients regardless of age. In order to apply the pneumonia algorithm, the patient must meet at least one of the bullets in footnote number 10. And if the immunocompromised definition is not met, you cannot apply the pneumonia algorithm to that patient. Sorry, the pneumonia 3 algorithm to that patient. There are a few more key points about the signs and symptoms element that I want to highlight. Fever, leukopenia, and leukocytosis must meet the defined parameters within the algorithm. And do note that the leukocytosis parameters are different for pneumonia 1 alternative criteria for infants and for the pneumonia 1 alternative criteria for child. When assessing breath sounds, remember that wheezing and rhonchi are only eligible to meet pneumonia 1 alternative criteria for infants less than or equal to 1 year old. Wheezing and rhonchi are not eligible for use for meeting pneumonia 1 any patient, pneumonia 1 child, pneumonia 2, or pneumonia 3 criteria. And as always, don't forget about the footnotes. The guidance in the footnotes must be considered when determining if the signs or symptoms are met. And I do want to highlight a couple of the footnotes, number 3 and number 5, as we often receive questions about these. Footnote number 3 addresses the requirements for purulent secretions. Purulent secretions must meet the parameters in the footnote. The secretions must contain at least 25 neutrophils and no more than 10 squamous epithelial cells per low power field, and these results can be found in the laboratory gram stain report. Clinical documentation of the descriptor purulent, for example, documentation of purulent sputum, does not meet this criterion. Footnote number 5 addresses the requirements for tachypnea. There must be a documented respiratory rate within the pneumonia infection window period that meets the age-based parameters in the footnote. And remember, when NHSN provides specific parameters for value, you must apply the NHSN parameters and not your facility's parameters. So for example, an adult patient must have a documented respiratory rate of more than 25 breaths per minute to meet the requirement for tachypnea, regardless of your facility's parameters for tachypnea. Additionally, clinical documentation of tachypnea does not meet this criterion. And here is knowledge check number 4. The Pneumonia 1 alternative criteria for infants less than or equal to 1 year old can be used with the Pneumonia 2 and the Pneumonia 3 algorithms.
Okay, Jennifer, we are seeing B overwhelmingly. Just one A so far, but all Bs.
Great job. The answer is false. The Pneumonia 1 alternative criteria for infants less than or equal to 1 year old can only be used with the Pneumonia 1 algorithm. Pneumonia 2 and Pneumonia 3 do not have age-specific signs and symptoms criteria. All right, finally, we're going to look at laboratory test evidence for meeting Pneumonia 2 and Pneumonia 3. And while there are several laboratory tests within the algorithms that can be used to meet the pneumonia definition, in this section, I will be highlighting the most commonly used laboratory elements. So please remember to refer to the algorithms in the protocol for a comprehensive list of available laboratory tests and results for meeting the pneumonia definition. The first step when evaluating laboratory test results is to determine if the identified pathogen is eligible for use in meeting pneumonia. For the pneumonia definition, all Candida species or yeast not otherwise specified, all coagulase negative Staphylococcus species, and all Enterococcus species are excluded as pathogens unless identified from lung tissue or pleural fluid. If any of these pathogens are identified from blood, they can only be attributed as a secondary BSI pathogen to pneumonia if Pneumonia 2 or Pneumonia 3 is met with a matching organism isolated from lung tissue or pleural fluid, and the blood specimen is collected in the secondary BSI attribution period. The only exception to these pathogen exclusions is when meeting the Pneumonia 3 for immunocompromised patients. In that situation, if there is a matching Candida species isolated from both a respiratory specimen and a blood specimen, and these two cultures can be used to meet the Pneumonia 3 definition, then Candida is an eligible pathogen. Otherwise, Candida is only eligible as a pathogen when isolated from lung tissue or pleural fluid. All right, let's start with Pneumonia 2, Table 2. And the first laboratory element we'll review is organism identified from blood. If you have a blood specimen with an eligible organism for meeting pneumonia that has a collection date in the pneumonia infection window period, the eligible organism in the blood can be used to meet the pneumonia definition as long as the requirements in footnotes number 8 and number 12 are met. As per footnote number 8, the organism exclusions apply. So Enterococcus species, coagulase negative Staphylococcus species, and Candida species and yeast not otherwise specified identified from blood cannot be used to meet this laboratory element. And footnote number 12 indicates that for the blood specimens, results from both culture and non-culture based testing methods are eligible. Next, we're going to look at positive quantitative culture or corresponding semi-quantitative culture results from minimally contaminated lower respiratory tract, or LRT specimens, which are specifically bronchoalveolar lavage, protected specimen brushing, and endotracheal aspirate specimens. And as you can see, information from footnote number 9 is part of this laboratory element. Footnote number 9 in the first bullet specifies that sputum and tracheal aspirate specimens collected from non-ventilated patients are not minimally contaminated and cannot be used to meet this laboratory element. Additionally, footnote number 9 directs you to Table 5 for threshold values of growth of pathogens on culture. So remember, the laboratory requirement is for a positive quantitative culture or corresponding semi-quantitative culture result. And Table 5 provides the threshold values of quantitative growth on culture that must be met for the eligible specimen types. If the quantitative thresholds are not met, or the semi-quantitative equivalents are not met, the culture results cannot be used to meet pneumonia. So for example, if the culture result simply identifies E. coli, the laboratory requirement is not met. The culture result must specify an eligible quantity, such as greater than 100,000 CFU per mil of E. coli from an endotracheal aspirate specimen, or an eligible semi-quantitative result, such as 4 plus E. coli or many E. coli. Next, we're going to look at organism identified from pleural fluid and positive quantitative culture or corresponding semi-quantitative culture result of lung tissue. Both of these elements refer you to footnote number 9 for the information in the second bullet, which is to remind you that Candida species and yeast not otherwise specified, Enterococcus species, and coagulus negative Staphylococcus species are eligible organisms when identified from these specimens. Additionally, pleural fluid refers you to footnote number 12, which states that results from both culture and non-culture-based testing methods are eligible for use. And lung tissue refers you to Table 5 for the quantitative and semi-quantitative threshold value requirements for organism growth on culture. Additionally, both of these specimens have collection requirements that must be met for the specimen to be eligible for use. And these are specified in footnote number 9 for pleural fluid and Table 5 for lung tissue. Moving on to Pneumonia 2, Table 3. We often get questions about the first laboratory element, virus, Bordetella, Legionella, chlamydia, or mycoplasma identified from respiratory secretions or tissue. And for this element, the organisms can be identified by either culture or non-culture-based testing methods. And posterior nasal swab and nasopharyngeal swab specimens are eligible specimens for meeting this laboratory requirement. Now let's look at pneumonia 3 for immunocompromised patients in Table 4. And the identification of matching Candida species from blood specimen and respiratory specimen. In this specific laboratory element, sputum and tracheal aspirate specimens collected from non-ventilated patients are eligible for use. And again, there are footnotes that apply. Footnote number 11 indicates that a sputum specimen is an eligible specimen and that any quantity of Candida identified is eligible. So Table 5 requirements do not apply. The result can simply identify a Candida species and be eligible for use. And footnote number 12 indicates the organisms can be identified by either culture or non-culture-based testing methods. Do note, however, that this laboratory component only applies to matching Candida species identified from blood specimen and the listed respiratory specimens. This laboratory element cannot be used with Enterococcus species or coagulus negative Staphylococcus species. Under the laboratory column in Pneumonia 3, you'll see or any of the following from laboratory criteria defined under Pneumonia 2. And what does this mean? It means that any of the laboratory elements listed in the pneumonia algorithm in tables 2 and 3 can be used to meet Pneumonia 3 as well. But don't forget, the footnotes associated with the laboratory elements also apply when meeting Pneumonia 3. So for example, if you have Enterococcus faecalis identified from a blood specimen, it cannot be used as an element in the infection window period to meet Pneumonia 3, since as we reviewed a few slides ago, the footnote number 8 organism exclusions apply when using this laboratory element to meet Pneumonia 2 or to meet Pneumonia 3 using laboratory findings from Pneumonia 2. And here's our next knowledge check. An endotracheal aspirate specimen with a final culture result of greater than or equal to 10 to the 5th CFUs per mil of Enterococcus faecium can be used to meet pneumonia criteria. True or false?
Jennifer, they started answering before you finished, and they are all saying false.
Excellent. You guys are batting 100% today. Is that a mixed metaphor? I'm not sure. The answer is false, and let's break this one down. There are 3 parts for meeting this laboratory element. First, you want to look at the specimen, and endotracheal aspirate is an eligible specimen. The next thing you want to do is look at the amount of growth. And for endotracheal aspirate specimen, greater than or equal to 10 to the 5th CFU per mil does meet the Table 5 quantitative values requirement. And the next thing you want to look at is the organism. Enterococcus faecium can only be used to meet Pneumonia 2 or Pneumonia 3 criteria when identified from lung tissue or pleural fluid. So, because Enterococcus faecium is an excluded organism, this laboratory result cannot be used to meet Pneumonia 2 or Pneumonia 3. Great job, everybody. All right. Lose right through that one. Anyway, since the pneumonia definition is frequently used as a site-specific infection for secondary BSI attribution. Oh, sorry, I lost my spot. Yes, let's look at some examples for correctly assigning a secondary BSI to pneumonia. As Latasha presented in the secondary BSI attribution session, in order for a BSI to be determined as secondary to another site of infection, a site-specific definition, in this case pneumonia, must be met, and either secondary BSI scenario 1 or secondary BSI scenario 2 must be met. And I'll give you a moment to review the slide and refresh your memory as to what these scenarios entail. All right, a couple of things to note before we begin. Pathogens cannot be reported for Pneumonia 1 events. The Pneumonia 1 criterion does not include a site-specific specimen or a blood specimen, and therefore a secondary BSI cannot be assigned to Pneumonia 1. However, pathogens can be reported for Pneumonia 2 and Pneumonia 3 events. Therefore, a secondary BSI can be assigned to Pneumonia 2 and Pneumonia 3 if one of the secondary BSI scenarios is met. And we'll start by applying secondary BSI scenario 1 for matching pathogens. In this example, Pneumonia 2 is met with a bronchoalveolar lavage culture identifying many E. coli. And remember that many is an acceptable semi-quantitative culture result for meeting Pneumonia 2. Additionally, there is a blood specimen collected in the secondary BSI attribution period with a matching organism to the site-specific specimen used to meet Pneumonia 2. And the BSI can be assigned as a secondary BSI to the Pneumonia 2 event. And remember the excluded pathogens. What happens if they are identified in a blood specimen collected during the secondary BSI attribution period? If excluded pathogens are identified from blood, they can only be attributed as a secondary BSI to pneumonia if pneumonia 2 or pneumonia 3 is met with a matching organism identified from lung tissue or pleural fluid, and the blood specimen collection date is in the secondary BSI attribution period. In this example, Enterococcus species is identified from pleural fluid, which can be used to meet pneumonia 2. Remember, Enterococcus species are not excluded from pneumonia when identified from pleural fluid or lung tissue. And the BSI with a matching pathogen and a collection date in the secondary BSI attribution period can be assigned as a secondary BSI to pneumonia 2 in this scenario. And the determination is a pneumonia 2 with a secondary BSI with Enterococcus species as the pathogen. And additionally, regarding the excluded pathogens, pathogens excluded from the pneumonia definition are also excluded as pathogens for BSIs secondary to pneumonia, even if identified in the same blood specimen as an eligible pathogen. So in other words, they can't be scooped. Instead, the excluded pathogen must be accounted for as either a secondary BSI to another site-specific infection or reported as a primary BSI. And this is covered in Chapter 2 in the Pathogen Assignment Guidance section. And we'll look at an example. In this example, pneumonia 2 is met with a bronchoalveolar lavage culture identifying 4+ growth of Klebsiella pneumoniae, which is an acceptable semi-quantitative culture result from meeting pneumonia 2. Additionally, there is a blood specimen collected in the secondary BSI attribution period with a matching organism to the site-specific specimen used to meet pneumonia 2, Klebsiella pneumoniae, as well as identification of vancomycin-resistant Enterococcus. Remember, when Enterococcus species are identified from blood, they can only be attributed as a secondary BSI pathogen to pneumonia if pneumonia 2 or pneumonia 3 is met with a matching organism identified from lung tissue or pleural fluid. So in this example, the VRE in the blood cannot be assigned as a secondary BSI pathogen to pneumonia. Now let's move on to secondary BSI scenario 2. Remember, secondary BSI scenario 2 is met when an organism identified in the blood specimen is used as an element in the infection window period to meet the pneumonia definition. For pneumonia, there are 2 laboratory elements from the pneumonia 2 and the pneumonia 3 algorithms in which blood can be used as an element to meet pneumonia. And these are from Table 2, organism identified from blood, and from Table 4, the identification of matching candidate species from blood and sputum, endotracheal aspirate, bronchoalveolar lavage, or protected specimen brushing, and the blood specimen and respiratory specimen have collection dates that occur in the same infection window period. So we'll look at our first example, and this one is pretty straightforward. A blood specimen with Staphylococcus aureus, which is an eligible pathogen for meeting pneumonia, is collected within the pneumonia infection window period, and the organism is used as an element to meet pneumonia 2, and the BSI is attributed as a secondary BSI to pneumonia. Next, let's look at pneumonia 3 for an immunocompromised patient. The patient is HIV positive with a CD4 count less than 200, which meets the pneumonia immunocompromised definition in footnote number 10. And there are blood and respiratory specimen with collection dates in the same infection window period that have a matching candidate species identified. And remember, as per the matching organism guidance, which can be found in both the BSI chapter and chapter 17, Candida species and Candida albicans are considered matching organisms. So the Candida BSI can be attributed as a secondary BSI to pneumonia 3 in this scenario. And remember, this laboratory element is specific to Candida species only. All right, we made it. Now that we've completed our review of the pneumonia surveillance definition, let's apply what you've learned to some case studies. And here's our first case study. Which pneumonia criterion is met in this scenario? Pneumonia 1, pneumonia 2, pneumonia 3, or no pneumonia criteria are met? And I'll give you a bit of time to review and place your answers in the chat.
Jennifer, we're seeing mostly B's with a couple of A's scattered in. Up and a C.
Okay. Kind of all over the place, as Emily said, alphabet soup. Let's discuss. Since a pneumonia surveillance definition cannot be met unless the imaging requirement is met, the first thing we will do is review the imaging picture. And in this scenario, the day 4 imaging demonstrates new evidence of pneumonia that is persistent in subsequent imaging tests on days 6, 7, 9, and 11. And remember that sometimes radiologists will use different terms to describe the same findings. In this case, the term infiltrates and opacities are used to describe the same persistent finding, and the imaging requirement is met. The day 4 imaging test with new definitive evidence of pneumonia that is persistent sets a pneumonia infection window period from day 1 through day 7. The next step is to determine if signs and symptoms and laboratory evidence of pneumonia are present in the pneumonia infection window period. In this scenario, on day 5, there is an endotracheal aspirate culture with an eligible organism identified, but the growth of 1+ does not meet the semi-quantitative growth requirement from Table 5, so the culture result is not eligible. Since there are no eligible laboratory results in the infection window period, neither pneumonia 2 nor pneumonia 3 can be met. But you can still evaluate whether pneumonia 1, which does not require a laboratory element, can be met. And remember, to meet pneumonia 1, there must be a fever or leukocytosis or leukopenia or altered mental status with no other recognized cause for patients 70 years old or older, plus at least 2 additional signs and symptoms in the infection window period. In this case, there is leukocytosis on day 3, as well as fever on day 6, but they both meet that first part of the definition for fever or leukocytosis or leukopenia. And on day 6, there are rails, but there are no other signs or symptoms in the infection window period, so pneumonia 1 cannot be met. So the determination in this case is D, no pneumonia criteria are met. All right, let's move on to case study number 2. Can the blood culture be assigned as a secondary BSI to pneumonia in this scenario? Take some time to make your determination, and then I will we'll discuss.
Mostly no and a handful of yeses.
Weird because it's muted.
All right, thanks, Mary. A mixture of responses, so let's review the case. Again, the first step is to evaluate the imaging. Remember, we are looking for imaging with new and persistent or progressive and persistent definitive imaging test evidence of pneumonia. The day 1 imaging demonstrates opacities, which is potentially a positive finding, but the day 2 imaging test does not demonstrate pneumonia, and the day 4 imaging test attributes the opacity to something other than pneumonia, so these imaging tests are not eligible for use. The day 5 imaging test demonstrates a progressive finding that is equivocal for pneumonia. And remember, when imaging test findings are equivocal for pneumonia, you must first look to subsequent imaging for clarification. The days 6, 9, and 11 imaging tests demonstrate definitive findings for pneumonia, which clarifies the day 5 imaging test as representative of pneumonia, and therefore it can be used to meet the image requirement and set a pneumonia infection window period from day 2 to day 8. All right, in this case, we are trying to determine if the day 7 blood culture can be assigned as a secondary BSI to pneumonia. The organism in the day 7 blood culture is an eligible organism for meeting pneumonia, and the blood specimen collection date is within the pneumonia IWP, or infection window period. So you will want to determine if pneumonia 2 can be met using the blood culture as an element, which it can, since there is also leukocytosis in day 3, and at least one qualifying sign and symptom, the day 6 worsening gas exchange, within the infection window period. But there is also a bronchoalveolar lavage specimen within the infection window period with an eligible organism with a semi-quantitative growth on culture that meets the Table 5 semi-quantitative requirements. And this result can also be used to meet pneumonia 2. However, the organism in the bronchoalveolar lavage does not match the organism in the blood. And this is a scenario that we commonly receive questions about. If the organisms in the infection window period from the blood specimen and the respiratory specimen don't match, can the BSI still be assigned as secondary to pneumonia? And the answer is yes. Matching organisms is only required when applying secondary BSI scenario 1, where the blood specimen with a collection date in the secondary BSI attribution period, but outside the infection window period, must have a matching organism to the organism in the specimen that was used to meet the site-specific definition. In situations where the blood specimen has a collection date in the infection window period and can be used as a laboratory element in the infection window period to meet the site-specific definition, the BSI is attributed as a secondary BSI to the infection, as per secondary BSI scenario 2. So in this case, pneumonia 2 is met twice in the same infection window period, once with the bronchoalveolar lavage culture and once with the blood culture. So you would report a pneumonia 2 event with a secondary BSI, date of event, day 3, and both pathogens would be reported to the event. All right, I'm going to move on to our final case study. Thanks for hanging in here with me. Once again, we're going to evaluate whether or not the blood culture can be assigned as a secondary BSI to pneumonia. And I'll give you some time to review the case.
All right, a little slow starting, but overwhelmingly yes.
All right, good job. Let's discuss this case. This case pulls together several concepts from Chapter 2, Identifying HAIs, and from Secondary BSI Attribution Guidance. But since we are applying the pneumonia definition, the first step is to evaluate the imaging for new and persistent or progressive and persistent evidence of pneumonia. In this scenario, the day 4 imaging test demonstrates new evidence of pneumonia that is persistent in the subsequent imaging test on day 7, and the imaging requirement is met. So you may be wondering, why did I only mention the day 7 imaging test? Remember, we recommend that you review available imaging for persistence for about 7 days, and the only imaging available for review within 7 days of the day 4 imaging test is the imaging test performed on day 7. So these 2 imaging tests can be used to meet the definition. Actually, you know what? I just realized it actually goes through day 9. Sorry. Sorry that my graphic doesn't match my explanation. You can go through day 9 and you use the 3 imaging tests within the 7 days. So in this scenario, that day 4 imaging test, which is not on this, sorry, that day 9 isn't on this one. Pretend it is. The day 4 imaging test sets a pneumonia 1 infection window period from day 1 through day 7, during which pneumonia 1 is met with the day 1 fever and day 2 tachypnea and day 2 rales. The date of event is day 1, which sets a pneumonia secondary BSI attribution period from day 1 through day 14, and a pneumonia repeat infection timeframe from day 1 through day 14. There is a positive blood culture collected within the pneumonia secondary BSI attribution period on day 12, but a secondary BSI cannot be assigned to a pneumonia 1 event because there is no site-specific organism to which the blood culture organism can match. The blood culture also has a collection date in the pneumonia repeat infection timeframe, but the pneumonia repeat infection timeframe only applies to subsequent pneumonia events. So a BSI with a collection date with a pneumonia RIT cannot just be added to the pneumonia event. Remember, in order to assign a BSI as secondary to another site of infection, one of the secondary BSI scenarios must be met. In this case, we have already determined that secondary BSI scenario 1 cannot be met. However, if secondary BSI scenario 2 can be met, in other words, if pneumonia 2 can be met using the blood culture as an element in the pneumonia infection window period, and the date of event is within the pneumonia repeat infection timeframe, the BSI can be attributed as secondary to pneumonia. So let's look at how this happens. So you may be wondering how pneumonia 2 can be met if the imaging tests around the time of the blood culture do not demonstrate new or progressive evidence of pneumonia. If the infection definition is remet within the repeat infection timeframe, it is not considered to be a new event. It is considered to be an ongoing continuation of the initial infection event that sets the repeat infection timeframe. Because of this, within the repeat infection timeframe, it is not necessary to show new or worsening imaging test evidence of infection. That has already been met for the initial pneumonia event, and we would only expect to see persistent imaging test evidence of an infection in the repeat infection timeframe. This is not to say that there will not be new or progressive imaging test evidence of pneumonia in the repeat infection timeframe. There may be. It just means that persistent imaging test evidence of pneumonia is sufficient, and new or progressive imaging findings are not required for meeting a pneumonia criterion within the pneumonia repeat infection timeframe. So in this scenario, the day 12 blood culture, which is the first diagnostic test around this time that can be used to meet the pneumonia definition, sets a pneumonia infection window period from day 9 through day 15, during which pneumonia 2 is met with the day 11 fever, the day 12 blood culture, and the day 13 dyspnea, and the day 13 imaging test with definitive evidence of pneumonia. The pneumonia 2 date of event is day 11, and since the date of event for re-meeting the pneumonia definition is within the pneumonia RIT, or repeat infection timeframe, the day 12 BSI is attributed as secondary to the day 1 pneumonia event. And when reporting the event, you would upgrade the pneumonia 1 to pneumonia 2 as per that reporting hierarchy we talked about earlier. And you would add the BSI pathogen to the event. And remember, as per Chapter 2, the original date of event, which in this case is day 1, and the original repeat infection time frame, and the original secondary BSI attribution period do not change. And this scenario is covered in the pneumonia FAQ number 10 on the Pneumonia Facts webpage. All right, this concludes our case study section. Thank you for your participation and for hanging in with me for this 2025 NHSN presentation of pneumonia surveillance. Do we have time for me to answer questions?
Sure, there's time for a couple of questions.
Okay, Melissa, I think you're monitoring the Q&A box. Is there anything in there for me to answer?
Yes, we had a few. We had a little issue with the Q&A box, so I was able to capture a few questions before that. There is one question that came through that says they're a little confused about imaging the terms definitive versus eligible versus equivocal. For example, does the when the slide uses the term eligible, does that mean definitive? So wondering if maybe you could cover just a little bit more on that imaging component.
Okay. So eligible findings for, or potentially eligible findings for pneumonia are those definitive findings, the infiltrates, the consolidation, the cavitation, the nematoceles. Potentially eligible findings would be those non-specific findings of opacities, densities, airspace disease that could potentially be considered as eligible findings for pneumonia if they're not attributed to something other than pneumonia. Findings that are, those infiltrates, consolidation, cavitation, and nematoceles are definitive. Equivocal findings are potentially eligible if they're determined to be definitive findings. So, for example, if you have equivocal findings that are supported by clinical correlation, those now become eligible findings for use in meeting the pneumonia requirement. So I'm sorry if my interchanging of those words without really defining them caused some confusion.
Great, thanks for clarifying, Jennifer. I just saw one come through the chat here that says, are there any excluded organisms for NEW2 with the blood culture? And I know you touched on this, but maybe if you could reiterate the excluded organisms for pneumonia.
Yeah, for pneumonia, the excluded organisms include all Enterococcus species, all coagulus negative Staphylococcus species, and all Candida species and yeast not otherwise specified. So if those organisms are identified in a blood culture and the blood culture is within the pneumonia infection window period, that blood culture cannot be used to meet pneumonia. The only time that those excluded organisms can be used to meet the pneumonia definition when recovered from a specimen in the infection window period is if those organisms are identified in a pleural fluid or lung tissue specimen. And again, the only exception to this is when you have that matching Candida species with a matching respiratory specimen with collection dates in the same infection window period. And that only applies for patients who meet the immunocompromised definition for pneumonia 3.
Great, thank you, Jennifer. Sorry, I'm just scanning the chat here. Can you please go back over the rationale for why the pathogens do not have to match for secondary BSI scenario 2?
Oh, go back to that slide. Okay, I believe this is the slide they're talking about. So in this scenario, because you can use that blood culture in the infection window period as an element to meet the pneumonia 2 definition, it does not have to have matching organism. It meets secondary BSI scenario 2, which only requires you to have a blood specimen with an eligible organism in the infection window period. So in this case, that does meet pneumonia 2. So whether or not that BAL culture is there, that blood culture still meets pneumonia 2 and is still considered secondary BSI to pneumonia. So it does not have to match that organism from the BAL. The BAL independently also meets the pneumonia 2 definition. So you've actually met the pneumonia 2 definition twice, once with the BAL culture and once with the blood culture. So they don't have to match in this scenario. And there are a couple more examples on how to apply this concept in the BSI chapter that you can take a look at. Anything else, Melissa?
There are a few questions that have arisen about case study number 3 in general. Can you go over the case study 3 with new 1 and new 2? Yeah, I'm not seeing, yeah. Are you seeing anything different, Mary?
Is there a specific part of that I can zero in on, or?
There's no clarification, so I'm a little unclear. One question says, so both organisms will be entered when reporting to NHSN. That was referring back to the last question that you just answered.
And both organisms would be recorded and reported.
Okay.
I think overall there was just a lot of confusion around case study 3 with asking you to re-review it, which you did.
Yeah.
Okay.
Thank you for taking the time to do that, Jennifer. Yeah, I'm not seeing much else.
All right. Thank you all for your questions and your attention. And if you have any questions that were not answered today, or if you have a need for additional guidance or clarification or assistance with applying the pneumonia surveillance definition, please submit your questions and case reviews to the NHSN Help Desk, either via the NHSN ServiceNow portal or via email to nhsn@cdc.gov. And thank you so much.